Our next session is a conversation. And we did this for the first time last year, and it ended up being one of our most highly rated sessions probably ever. And so what we are going to do for the next hour and a half is bring up 7 panelists from around the country, some of whom you've already heard from, and we are going to just talk about ethics and specific cases and how they would respond. And we may also get into some of their perspectives on ethics consultation and how it should be done and so on. And what I am going to do is engage them for about an hour, and then there will be a half an hour where the audience is going to be engaging. So as you come up with questions or issues, and they can be related to either the sessions we've already had this morning or some of the issues that may be raised as I talk to the panelists, or just issues from your own experience. Write those down, and we'll have microphones in the aisle, and starting at about noon, we'll be letting you guys all participate. So I'm going to have the panelists come up and sit under your name so people don't get too confused. I'm going to... Starting at guard. Okay. Norm Faust. All right.
But you need the light show if you're going to do that. You need heights and weights.
Heights and weights. Okay, so you've met 3 of these panelists already. And the others who are joining us up here include Kelly Lang. Kelly is both a nurse and a lawyer who is currently an assistant adjunct professor of bioethics and medical humanities at the Medical College of Wisconsin's Center for Bioethics and Medical Humanities. She has had a long-standing interest in ethics and has been doing work in ethics for many years. She serves on the Children's Hospital of Wisconsin Ethics Advisory Committee and also serves as an ethics consultation team leader and nursing ethics consultant there. John Lantos is the director of Children's Mercy Bioethics Center at Children's Mercy in Kansas City. Prior to moving to Kansas City, he was a professor of pediatrics at the University of Chicago and served as chief of staff at La Rabida Children's Hospital, as well as chief of the Division of General Pediatrics and associate director of the McLean Center there. He now is director of the Children's Mercy's Bioethics Center. He has also served as president of the American Society of Law, Medicine, and Ethics, and president of the American Society of Bioethics and Humanities, and worked on President Clinton's Healthcare Reform Task Force. Dr. Lantos is a multiply published author, including many books, several of which you can find out on the table, the book table out there at the break. Micah Hester is chief of the division and professor of medical humanities at the University of Arkansas for medical sciences. He coordinates the Pediatric Ethics Consortium, which is a web-based consortium of people like many of the people here today who work in pediatric ethics. He has also is responsible for developing the Pediatric Ethics Affinity Group for the American Society of Bioethics and Humanities, and is also a multiply published author, and his authorship includes 9 books. His latest is Guidance for Healthcare Ethics Committees, which again is out on the table at the book table. And then finally, Sara Rosenthal is an associate professor of bioethics in the departments of internal medicine, pediatrics, and behavioral sciences at the University of Kentucky, where she also directs their program for bioethics and chairs their hospital ethics committee. She directs the ethics consult service for both the adult and pediatric hospitals, and has also published many articles, many of which are related to ethics and some of the issues that come up in endocrinology. So welcome to all of our panelists. And I think we're going to just start in with some sample cases. And what I have done is sort of called a number of situations that seem to arise more frequently than one might think, but raise some really compelling questions. And so this first case is a bit of an amalgam, but it represents a very common issue that I think ethics consultants wrestle with. So this is a 13-year-old boy who has autism and developmental delay. And recently he's been exhibiting sexualized behavior, which according to his mother includes masturbating in public and in front of his mother. He has sexually touched a female student at his school. He not infrequently rubs up against others with his genitals. And most recently, he's climbed on top of a relative while that person was sleeping and began simulating sexual activity. The child is actually aware of his behavior, and he has said that he would like for it to stop, but that he can't control it. He also has issues with agitation and aggression. He's currently on anti-anxiety meds for that, including risperidone. He is developmentally delayed, but he can participate in some decisions depending on his emotional state at that particular time. So the question that's raised by this case is what sorts of measures are appropriate here? The boy's mom would like to stop his sexualized behavior, but she also wants to assure that he won't make anyone pregnant should that happen, since he's physically but not mentally capable of fathering a child in her mind. So what sorts of options do we have here? What would be appropriate? Options might include a vasectomy, might include castration, might include Lupron, and you may have other ideas. So thoughts on that case?
No.
No.
Well, I mean, I guess I'll start since I said no. I'm looking at this, and as a philosopher by training, I'm saying to myself, I don't know any of this. I know that I want to know, when I'm confronted with cases like this in an ethics consult, one of the first things that strikes me is, what would we consider to be the least invasive approach to this problem that would get us at least moving towards, if not actually accomplishing, the goal of him not wanting to be quite so sexualized in his behavior, and also helping alleviate some of his mom's concerns. And so I would actually start by asking, what do we think that is? Not being a physician, I'm not going to speculate on what we think those least invasive options are. So that's how I would start this case.
Go ahead, Norm.
There are at least two issues here. One is just a medical question of what's the most medically effective and safest way to deal with his sexual aggression. And none of us on the panel are experts in that. I tried to do some review of that, and there is some evidence that Lupron or Lupron is effective in a substantial number of people with this kind of behavior with acceptable side effects. Whether I agree we should be the least invasive way of treating it. So if there are psychiatric behavioral ways, obviously they should be tried, but probably not. That is, from what I've read, usually chemical treatment. So I don't think there's any reason to shrink. It's in his interest to have that behavior treated, because he's going to get into criminal trouble. He's going to wind up in prison or incarcerated in a hospital if it continues. So that's just a medical question of what's the best way to treat behavior that's not in his interest or anybody else's. On the sterilization thing, if his sexual behavior can be attenuated so that he's not at risk of impregnating anybody, that would be the best thing. But I don't think we should rule out sterilization as being in his interest also, as well as potential victims of his sexual assault. I think sterilization has a bad reputation in America because of the eugenic sterilization of 100,000 or more people with developmental disabilities, most of them inappropriate. But the overreaction to that, and Wisconsin leads the way at overreacting to that. We have a Supreme Court decision that says you can never sterilize a minor until the legislature gives us permission to do it, and they never will. And that's not in the interest of a lot of kids with developmental disabilities for whom procreation would be a disaster, that is pregnancy or inflicting a pregnancy. So if it's the case that this fella is never going to be capable of being a parent, and I can't tell quite that from the limited history here, And it may not be the case. But if I just want to say that the country's overreaction to sterilization, like it's always wrong, it's always terrible to involuntarily sterilize somebody, is not true, and it ought to be at least on the table as something that might be in his interest. Plus, a vasectomy at least can be reversible. So I don't know that he meets criteria yet for that, but I wouldn't rule it out.
Paula?
Hi. Ooh, that's loud. I'd like to suggest that, at least looking at the context, that the answer to the question also has to do with what the social, emotional, and developmental goals of this family are. So for instance, if the boy is mainstreamed, then we're having to balance his own interests against the interests of the public to feel safe. So I would first want to entertain some kind of a discussion with the family and the boy about what are his social goals, what are his, what are we trying to achieve here. I do agree with Micah that the least restrictive option is the right action. I don't, that's a very interesting suggestion, Sarah. And I think that what you're probably suggesting is that there needs to be some way to redirect what is a normal, it's the expression of sexuality at the age of 13. I think that's, so not quite sure what we would do yet, but you could consider each option based on the answer to those questions.
So I'm hearing general consensus that the least restrictive and most reversible option should be the first choice. You don't agree with that, Kelly?
No, I agree. I just think there needs to be more exploration about what's going on with his child at age 13. It's assumed, I think, because of his autism and delay, oh, well, yeah, he's going to have these behavior issues, but there may be something else going on. Was he abused as a younger child or recently? Does that need to be explored? Is there cognitive or behavioral therapy that could be employed with or without medication to see if that could stop it? Because he's clearly distressed by his own behavior too, right? He wants it to stop. So that makes me think there's something else that may be going on besides just reverting to some sort of medical course. I think there are other questions that need to be answered before a final decision.
Okay. And assuming all of those things have failed, Lupron's failed, a surrogate's been engaged and failed. She's finding another line of work as we speak. Does anybody think a sterilizing procedure should be off the table in situations like this?
So the sterilization is this weird thing because it prevents pregnancy, but it doesn't prevent the inappropriate actions that could lead to pregnancy, right? I mean, the problem is his hypersexuality. Yes, a secondary impact of that could be to get someone pregnant, but that's not really the problem. The problem is the hypersexuality. So it's sort of a solution for the wrong problem.
Well,
although mom has two concerns.
Well, except the hypersexuality, testosterone is often contributing to that. That's why Lupron works. It's a testosterone lowering or opposing agent. But so if the Lupron doesn't work, castration is not likely to work either. So that's why the Lupron is a less invasive way of reducing his hormone levels.
And what mom is going to say is, if we can't fix this behavior, then I really want him not to be able to father a child.
But a vasectomy is a less invasive way of accomplishing that than a castration.
Or send him to a boys' school.
Assuming you can keep him in the all-boys school.
You want him pregnant.
Send him to a boys' school.
Lainey, would you have an issue with sterilization? I mean, if you were sort of at that point where the behavior didn't appear to be controllable, but mom has this second concern with a boy?
Well, I guess I'm having a hard time with it because I think it's only dealing with, so if he's sterilized so he can't impregnate, but he still assaults, I don't think we've achieved much. We've achieved some, but we haven't achieved enough. And so we really have to figure out how to prevent that. And yes, Lupron works. I have to say that back in the 80s, we actually had a patient like this who we actually put on high-dose beta blockers, which also prevented him from having high dose, really high dose, that prevented him from having erections, for example, which actually then prevented both the expression of the hypersexuality, at least in one form, as well as avoidance of pregnancy. So I think there are a lot of chemical things that we can do, which will leave him the option as he does develop and mature. He may not be mature at 18, but he may be mature at 30, but it still leaves open options for future sexual relationships and everything else. So I guess I'm sort of a little bit unhappy with a permanent and much more into a chemical castration at this time.
I think it's only acceptable if you're going to consider sterilization, then it would have to be there would have to be a very careful discussion with the boy, almost some form of capacity assessment to see what he truly understands and appreciates about his behavior. And it sounds like you're hinting at the case that he does have an understanding and appreciation, but it's an impulse control problem at this stage. And so dealing with autism spectrum-like issues, it is a spectrum, and a 13-year-old boy is very different than that same boy or that same child as a 17-year-old or an 18-year-old adult.
This is an 18-year-old with a 4-year history of anorexia nervosa. Her weight's down 20%. She now weighs 40 kilograms. She presents to the clinic with orthostasis, bradycardia in the 40s, signs of dehydration. She's admitted to the hospital for IV hydration. The next day, she demands to be discharged. She's 18. She has not been declared incompetent by any court. Should her decision be respected? Norm.
You never called me. I've had a lot of experience with this. We have what was probably the largest collection of hospitalized patients with eating disorders in the world. We had 32 inpatient beds for one period and 16 for an even longer period. And this was the most common ethics consultation we got for many years on these types of cases. And my short answer is this. Number one, assuming she has capacity, which most of these young women do, so she can't be involuntarily detained. She makes choices about to live her life in this way, and it's very dangerous, and it's on the edge, and it flirts with death, and it's amazing the mortality rate is not higher than it is, but a small number of them do die. Maybe it's due to miscalculation. So the only way to prevent her from killing herself from this behavior, or from dying from this behavior, is permanent hospitalization. Outpatient therapy is generally ineffective. Obviously, we should give her as much as we can, and with all of the psychiatric and psychological support. But in fact, the only way of keeping these patients alive is to keep them in a hospital forever. And in fact, that's the dilemma that we're usually called about, is patients who don't demand to be discharged, but demand to be retained. They say, if you send me home, I'm going to be, back with a potassium of 1.2 and near cardiac arrest. Most patients in our hospital, our adult patients, are there because of self-inflicted wounds due to health-related behavior. They eat too much, they smoke too much, they watch too much television, they don't take their medicines, and so on. And these are choices that people make, and we don't owe people permanent hospitalization at the enormous cost that would bring if that's the only way to. We have lots of diabetics and smokers and so on who we could keep alive a lot longer if we kept them in the hospital forever. But I don't think they're entitled to that, and I don't think, obviously, the country can afford that. So it's unfortunate that people have disorders that we don't have magic bullets for. But as long as she's adjudicated competent, which I agree with you, she almost certainly would be, and maybe already has been.
Should you try to have her declared incompetent? Some people would argue that the distorted thinking, the distorted body image constitutes a level of incompetence to make this sort of medical decision.
Well, two things. First of all, in our jurisdiction, it would be just going through the motions. We can make that assessment of capacity in the hospital and predict how that's going to come out. And we know from our own courts and judges that these patients are not likely to be adjudicated. But even if she were, what then? That gives you the authority to involuntarily detain her for how long? Forever? I mean, this disorder doesn't go away for quite a while. Sometimes it ameliorates as you get older, but she's 18. So the only way, what's adjudication going to do? Allow you to lock her up for how long? Years? That's the only way to really guarantee that she will live longer than otherwise.
What if she's 17?
Well, the issue is capacity, not competent, not the age. I mean, age, you know, we have arbitrary age cutoffs because you have to issue driver's licenses and decide who votes and who can join the military. But for medical decision-making, capacity is the issue. That's why we let teenagers who seem to be capable of making decisions to make important informed choices about reproductive behavior, sexually transmitted diseases, and so on. So I think capacity is the issue, but if you start, you know, if you want to just keep pushing that down to 16, 15, there's some point at which she's unlikely to be making informed choices. It's hard to say this is an informed choice. This is, nobody chooses to be anorexic or to have an eating disorder. So she's, I mean, what the brain chemistry of this that forces people or drives people into this kind of behavior, I don't know.
So I agreed with you about the 18-year-old, Norm, but I think you've missed something with the 17-year-old. This isn't a sexually transmitted infection. This isn't pregnancy, which all do a lot with respect to capacity, but it's actually not about capacity. It's about the fact that we sort of want these kids to get treatment, and however we can get them into treatment. The more we learn about the adolescent brain, we know actually that our brains are still developing through our mid to late 20s. And in fact, the mature minor statutes, actually, there was a very good article in Pediatrics in the last 2 months, which really shows that we're overexpanding them from an ethics that wasn't actually meant in the legal realm. And so as a 17-year-old, no matter how mature she is, we all agree that she's making really bad choices. And if a parent says, I want her, you know, hospitalized, I'm going to absolutely agree to hospitalize her until the day she turns 18 and signs herself out AMA. Because I do think that parents still have a chance. And we also know with the results from anorexia that the younger the individual is, that the higher likelihood of success in treatment. And so by the time they're 24 and 25 and we're still talking about hospitalizing them, the likelihood of success is actually quite low. But even in the late teenage years, there's still a one-third, right? One-third are going to outgrow this eventually. One-third are going to end up being so sick and dying from it. And one-third are going to have sort of a roller coaster. And I want to give her that chance for the 2/3 reasonable results.
So I guess I want to say I recognize all the problems that Norm raises with the capacity issue and whatever, but I'm even at 18, I'm still willing to say that it is that we have a responsibility to make sure to the best of our abilities, and we actually kind of suck at it, to determine if she has capacity. I mean, the definition of decisional capacity is the ability to make the decision before you, with all sorts of different caveats about understanding and appreciation and what have you. And this is one of those kinds of conditions that truly starts to at least push very directly on the capacity issue. So I think, at least on the healthcare side, we have a responsibility to do our due diligence on making sure of the capacity issue. I wouldn't just say because so many of the courts would typically say she has it, that's how the trend has been. For her, as an individual patient, I think we have that responsibility. And also, you know, this is one of those conditions that can be almost entirely refractory. I worry about, I want to talk with her and see in this dehydration issue and her wanting to send out AMA, something similar that we do in palliative care is talk about maybe a time-limited trial of something to keep her there long enough to keep conversation going rather than signing out literally the next day, at least as this is presented by Doug, you know, signing out the next day, to come up with a time-limited trial of some, you know, talk therapy and some other things and see if she's willing to buy that at least long enough to see where we can get with that. It might lay a footing for her willingness to come back into a clinic and be part of a clinic regularly. It might not, but I'm willing to say we have some more work we can do with her. If we do our due diligence and capacity, and she's determined to have it, and no one can kind of trump that within the medical establishment, and she wants to walk away after offering the time-limited idea, then she walks away. And that's a tragedy, maybe, but we have to live with some tragedies. John, you have something to add?
Yeah, I mean, to me, the best analogy to this is someone who's depressed and suicidal. I mean, this is a young lady who wants to kill herself. And the question is, and we know she wants to kill herself. If she said she was going to go home and take a gun and shoot herself in the head, we would do whatever we could to keep her in the hospital in the hope that we could treat the underlying psychological disorder so that she no longer felt like killing herself. So in that sense, it turns on what we think the prognosis is. A lot of psychiatrists say if somebody really wants to kill themselves, they're going to kill themselves, and there's nothing you can do to stop them. But most people who say they're going to kill themselves with some sort of treatment change their mind and eventually thank you for preventing them from doing it. So with that in mind, the key question here would be, is this disease treatable? And if so, would some restraint of her freedom in order to allow treatment to take effect be ethically justifiable? I'd say it would. Whether it's legal would turn, I think, on her age and whichever judge it comes before. But if she's 17 and her parents wanted her treated, I'd keep her in the hospital. If she's 18, I'd seek a court order. And if I didn't get one, I'd feel like I'd done all I could.
I do agree, John. My only question is, does this meet the definition of being gravely disabled? And certainly one can lack capacity. And I get your analogy about someone who's suicidal, and I guess it also depends on what jurisdiction you're in and how your, local county council, addresses these cases, and also what the policies are of your hospital. I think unless you seek judicial intervention, I think it would be really impossible to hold this patient. I think unless it's totally foreseeable that the person is going to go home and kill themselves with a gun. I mean, this is more of a passive death wish, right? So I think I don't necessarily think that analogy applies.
No?
I don't think the suicide analogy is a good one, John. First of all, these patients don't want to die. At least that's what they say. You ask them, do you want to die? No, they want to be rescued. And most of ours want to stay in the hospital forever because they're terrified that if they go out, they're going to die. So, yeah, okay, but maybe we don't have enough information. But secondly, suicide, as you say, the overwhelming majority of people who attempt suicide 2 years later are appreciative of having been rescued. They didn't want to die. They made the attempt for various reasons, to send messages out of anger and so on, but they don't want to die. And so rescuing them is really what they want, and it's the appropriate thing to do. The ones who complete their suicide, we don't have good follow-up studies on. So whether they were glad not to have been rescued or not, we don't know, but it's probably a different population, the ones who succeed. Second, so therefore the success of rescuing somebody from a suicide is successful both in the medical sense, you hopefully wind up with a life, and in the ethical sense, because you're doing what the patient really wanted you to do in the first place, anyway, and most of the time. So with the anorexic patients or the eating disorder patients, I think it's quite different. Now, this one, she says she wants to go out. I'm guessing she's not wanting to be discharged so she can, quote, kill herself.
No, she wants to be discharged because she doesn't think she has a problem.
Yeah, right, but I'm guessing she doesn't want to die. And with regard to what everybody said, I thought it goes without saying, we do everything we can. We provide as much therapy as we can. Whatever works, works. If you want to go through the ritual in Madison, Wisconsin of having a court hearing, fine, do it, but it's an elaborate ritual because we know who the judges are and we know what they're going to say.
So I'd like to turn to the other end of the spectrum.
I have one
Oh, okay.
comment. would like to agree with John that I do think it's at least similar to depression in that it's a mental illness. And so it sounds like she wants to go home and may be a threat to herself if she continues to refuse to eat. I'm not convinced that she doesn't have depression as a component or in addition to the eating disorder. So I would look to do everything I could, at least to make the argument that she not go home and let herself die or whatnot. So I think there's more that could be done, at least to advocate for her. I think because they're difficult cases and we don't have the answers, it's easy to say, well, she's 18, let her go, but I would at least try and explore something else. I also think there are good programs. The programs out there vary in their effectiveness, and where you live and your financial resources makes a difference into whether or not your treatment is going to be effective. And that goes to the issue of funding and who gets funding and who gets to get treatment. And I think it's really easy to look at somebody's insurance and say, well, oh well, she's 18. I just, as an ethicist, I wouldn't want to stop there at the age limit and say, okay, go ahead. But I do think, again, it's mental illness, which is a serious matter, as is depression, and I would take it seriously.
This, this next case illustrates an emerging issue in ethics. This is an 8-year-old who weighs 180 pounds. He's developed diabetes, hypertension, sleep apnea, and mild heart failure. He continues to gain weight rapidly despite involvement of a multidisciplinary team. His parents seem unable to control his caloric intake. Should you recommend that he be placed in foster care and take legal action to do so? Go ahead.
David Allen and Aaron Carroll and the late Todd Varnes, colleagues of mine, wrote on this a few years ago with a patient who, like this, who presented nearly dead with respiratory arrest and on a ventilator. And we argued that children with life-threatening morbid obesity, that is, who have at a high probability of dying while still in childhood, before they can make informed choices, should be rescued from this, and for exactly the same reasons that we rescue other children who are being abused or neglected. Now, I think the language of abuse and neglect is really unfortunate because these parents of these children are not unloving or uncaring or unwanting to bring about change. As a person who's been head of a child protection team for many years, I think the same is true of traditionally abused children. I think most parents that I see who abuse their children love their children quite a lot and want very much to do well by them, and for various reasons are unable to do so. So I think the language of abuse and neglect, which is quite judgmental and evaluative, is unfortunate. But those are the statutes that we have available to us, or the medical, in this case, the medical neglect statute, failure to provide necessary medical care, which in this case is simply dietary management. So the arguments for getting this child out of this life-threatening, dangerous situation, and if he's got sleep apnea, I don't know how close he is to arrest. It would depend in part how bad his sleep apnea is. But if we think he's on the verge of diabetes, fatty infiltration of his liver failure, and or sleep apnea, he needs to be rescued. The purpose of rescue is not to cure the obesity. That's hopeless. The purpose is not to make him non-obese, which is probably unachievable. The goal is to make him less obese, to get, and you only need to get from the 99.9999 percentile down to 99.99. You only have, I mean, if you can get him down 50 pounds, he's still terribly obese. But that gets these children out of the risk zone. I could go on because there are more complicated issues with other variables. But now, foster care means finding a home where there's some reason to think that the parents can control the icebox and the pantry and not have food in the home. At 8, there's a moderate likelihood of that succeeding because he's going to have less access to food from other sources. With adolescents, it's much harder where they're out and about and can get food on their own. So the criteria for intervening to me is not a novel one. It's the one we've been using for 60 years or so in other neglect cases in which children, and the threshold should be very high. An imminent harm, a high likelihood of imminent irreversible harm, usually meaning death in childhood.
Sarah?
So I think.
Can I just say one other thing? I want to add one thing. This is different from the traditional neglect cases in which separation from the parent is not necessary to achieve this. That is, placement in a relative's home, preferably one that lives down the block or around the corner, so he can have as much contact with his parent or parents as possible. It's just the icebox and the refrigerator and the pantry that are controlled. So it doesn't have the same sort of fear of him being harmed by being around his parents. You want to maintain as much contact with his parents on a daily basis as possible. Excuse me, Sarah.
So I think that this is a bit of a cultural competence situation. In a lot of cases, we get a lot of these cases in the state of Kentucky, which has one of the highest obesity rates in the country. And I think that you can't just look at this out of context with the entire sort of diabesity, sort of agribusiness issue in terms of what foods are available, particularly food deserts and food insecurity, et cetera, et cetera. And I think that the way that I would initially approach it, and perhaps this is only when everything has failed, I would initially approach it as it has to be dietary re-education for the entire family, because generally when you have a very obese child like this, the parents are also not eating well because there's a reason, and there may be other covert sort of socioeconomic, socioethical issues behind the obesity. So I would deal with it as a family problem and not immediately sort of look at separating the child from the parents. And in some cultures, I know this is done in Canada and a lot of the indigenous communities, they actually help to teach people how to go shopping. How do you navigate and buy good foods in a supermarket? But I think there has to be some awareness that this is a bit of a health disparities problem, and if you and I don't know what the details of the case are, but generally that's what's going on. Is it's a sort of a family issue. So I take it as a family sort of opportunity.
I think we should stipulate with all these cases that these severe interventions that Doug is presenting us with are last resorts, that obviously you contemplate removal from the home only after all these other, all known efforts at weight control have failed.
And so, Norm, I have a question about that. So, another possibility, so I agree with Sarah that there's a lot of cultural competence issues. There are also some medical causes, and that I'm assuming that in this case has been worked up and that this kid doesn't have any of those conditions. What happens if we put this youngster in foster care and he comes back 3 weeks later and he's gained 5 pounds?
Because of the vending machines at school.
Thing. What?
He has access to the vending machines at school.
And so what do we do then? Because I think that's why I like Sarah's solution, and I know that you're not against Sarah's solution. You're saying what happens when Sarah's solutions fail. So I'm going to push you, though. What happens when your solution fails?
The same thing you do when you put a child in foster care to make sure he gets his insulin or that he gets his chemotherapy or whatever, and they don't get it. Then that's not an effective foster home, and you try to find something else. And if you can't find anything else, then maybe there's no solution. But there's no point in having him in a foster home that's not achieving the desired result.
What do we know about children who tend to hop from foster home to foster home?
As Dr. Belger used to say, you got to have life to have quality of life. So the first thing, we're talking only about cases in which there's a high likelihood of death. That's what we're trying to prevent, is death in childhood. When he's 18, he can start to try to figure this out for himself. So is there trauma involved in sending somebody to a foster home? Yes. Is there even more trauma in 2, 3, and 4 choices? Yes, yes, yes. Is it better that he be dead than to go through those things? No.
But there's no proof that foster care is effective.
That's true of 80% of what we do in pediatrics, which is, according to FDA statistics, 80% of drugs prescribed for children have never been tested in children. So you make the best lemonade with the lemons we've got. You do what you think. I will say we don't have a lot of cases in this category because this idea is just a very novel one. It's just the last few years that people have tried to do that. I can tell you that we've had some success, and there's a case report here and a case report there of children losing 50, 100 pounds in the first 6 to 12 months of being in foster care, and those are life-saving weight losses. What's going to happen with 100 cases? I don't know.
So, but at what point, to go to address Sarah's point, okay, so we allow the state to take the child away, put them in foster care where they will hopefully lose the weight and not have horrific trauma from being separated from their families. But what about the state's responsibility in terms of the school lunches, in terms of what they're providing the child, in terms of food deserts, food insecurity? What about the state's responsibility there in food advertising, all the things that are impacting the obesity, which is now classified as a disease? At some point, if the state's going to say, we're going to take your child away because bad parents are overfeeding your child, and I don't think it's that simple, at some point the state has to take responsibility and say, well, and we're also going to make this, and this change because we recognize society's impact and influence on children and their eating habits.
Yeah, I think we should change all those things. I think we should cure poverty. I think we should have a much better country than we have. But while we're waiting for that, if I've got a kid on a ventilator who's going to die, if I send him back to that home, I think I need to do something now to keep him alive until that city on a hill gets built.
I think we agree that this child needs protection in some way. I don't believe that foster care is the answer because hope is not I think, a viable plan, hope that the kid will get better. I really like what Sara had talked about, is this happens in the family and the community context. And if there's either a camp or some kind of a program that would be time limited, and then at the same time, because it's not only treatment with the boy, obviously, and we need to be realistic about what we can offer, what we can afford. I do believe that foster care would result in more harm to this child, unless there's evidence to suggest that the constellation of this family, that there are other things happening where an eating disorder or obesity is one of many compelling problems.
Seems like there's a theme in the common theme in the three cases we're dealing with. They're all complex physical, psychological illness that maybe has a biologic component, certainly has a component of family dynamics or a psychological overlay. There's marginal autonomy of the patient, maybe some, maybe not so much. Treatment is unlikely but not impossible. It's not impossible that it would be beneficial. And so the question in all three is, in these situations, when is it permissible to trample on somebody's liberty for some slight possibility of some benefit or some possibility of benefit or averting harm? And I think what makes them all tough is sort of weighing those probabilities. You know, is the intervention going to be beneficial? How likely is the harm if we don't intervene? How much is the treatment directed at a biological cause versus a psychological cause, and which is the real cause that we ought to be addressing in each case? So I think that's what sort of makes them all tough, is we're trying to balance 4 or 5 different variables, none of which we have good data for.
So I think that's a great way of summarizing the three cases. So I'm intrigued because in the first case, so in this case, the first solution that Norm went to was foster care.
That's the last solution.
Well, the last solution after, but there is another alternative last solution, which could have been, for example, bariatric surgery. Right? And we haven't actually mentioned that. And that's sort of the same thing of, you know, what is the last? Castration was sort of the last, and we were all trying to look for chemical solutions. Why didn't we look for a chemical solution in this case, or even a surgical solution? Why did we immediately go for separating the family? So I guess it leads me to ask some more questions about the case. The first I asked was make sure it wasn't a genetic condition where this kid doesn't have control. Is this kid cognitively normal 8-year-old that could actually understand what would be happening if we actually tried to do some type of banding or something of that sort, and kept him in the family? Because I do think that while foster care might be the right solution, it's a pretty drastic one. It's the vasectomy of the first case.
So he's a typical 8-year-old. He's not as advanced as you were when you were 8.
I have to say, I'm sitting here thinking of foster care as the vasectomy of some case. It has its own issues. You know, Norm, you said, you know, where there's life, there's quality of life, and of course that's true. The problem
I said you have to have life to have quality of life.
Right. Sorry, exactly. You have to have quality of life. The problem is where the quality of life, you know, is it good or bad, right? I mean, that quality isn't in and of itself positive. It can be very negative. And I would say we'd have to know a lot about this case, and I think Lainey brings up a very good point there. We've got to get really creative and think better about all the possible options that might be available to us. But couldn't we at least imagine a particular case of a particular child where it, in fact, would be better for him to live in whatever family environment he lives in that may be very positive in many other aspects, and end up dying that way than it is to have him bounce around in foster care where it could be awful? I think there are some cases where we could imagine that.
Better off dead than foster care. Is that what you're positing?
Possibly. For a particular patient,
but
yes.
Since we can't know that in advance, I think the answer is no, that we're going to have to try foster care many times to number 2, 3, and 4 before we could ever get to your point.
No, I completely understand that. What I want to be sure that we're not equating is having quality of life means having good quality of life.
No, but I think one of the things that we have to understand, and one of the things that gets so frustrating when the state gets involved in any ethics consult, is that the state really can't make a quality of life judgment. It's a value judgment. So the only thing they can do is an objective best interest. And in general, objectively, it's better to be alive than dead. And so that's the only thing that they can do. They can't say whether this quality of life is really worse than death, which is what you're suggesting, that there are some quality of lives that are worse than death.
We certainly make that determination in some patients.
Correct, but to the extent that this is a pediatric patient, we're going to have to make the assumption that when we involve the state can only make an objective best interest that life is better than death for this child.
In extreme, did you want to go, Doug? Sorry.
Oh, I want to move on to a new case.
Okay.
Did you want to say one last thing?
The sample size is very small, but in one of the reported cases, a teenage girl who lost 100 pounds and was rescued from the brink of death says, I've never been, in a foster home, said, I've never been happier in my life.
Okay, so I have to
not assume
pediatrics,
foster care is not always Auschwitz, you know?
I'm going to apologize for picking 3 cases that were readily, easily disposed of. So what I want to do now is talk about Dr. Smith, who's just called you for some advice because she has several families in her practice who refuse to vaccinate their kids. She knows she can't force them to vaccinate. She's frustrated by their refusal, and she's considering asking them to leave her practice. And she feels fairly strongly that that's the right thing to do. She doesn't have the time to spend with them. She's tired of dealing with them. Is this okay?
Yes. I'm sorry, she's asking the kids to leave her practice or the parents to leave her practice?
They go together. She basically wants to tell the parents she will not be their pediatrician if they don't vaccinate their child.
Sure, she can, what we would do in our institution is we would, she could do it on a couple of, she could do it on the basis of conscientious objection. She can't continue to participate in this, and do what she believes is wrong, and she can transfer care. But she has to transfer care to somebody else, and that's how those policies work. But she can absolutely.
So can I push you on the conscientious objection one? Because conscientious objection is usually used in situations where you're being asked to do something. And she's not being asked to do anything other than continue caring for these children. She's being asked not to do something, which she wants to do, but which is not required by law.
She has a moral objection to
the parent's
standing
decision,
by. Well,
but
she has a
not
moral objection to standing by and watching these kids not be vaccinated, and she doesn't want to participate. That's how I would view it.
Parents put children at risk all the time. We drive them in cars. We do lots of things. And so, yes, ideally, patients are vaccinated. The danger of dismissing these patients is several-fold. The first is these kids are, in a sense, vulnerable and at-risk children. And if all the pediatricians in this room refuse to take care of them, these kids will fall through the crack. These are kids that you want to have a close relationship, because when the mother calls you that the kid has 102 fever and the rash that developed on the face and is spreading down, as a general pediatrician, you're thinking, in this kid, measles is high likelihood. I got to isolate this kid. I got to get this kid under treatment, and I have to do it quickly. If I don't know the child ends up in the emergency room exposing everybody. In fact, as I was flying in yesterday, I got a text that there was a child who developed measles in Illinois who was at the soccer game on Thursday and was in O'Hare Airport on Wednesday, right? So just think about how many kids are exposed. But if these children, while I disagree with the parents, if these children have access to a pediatrician, at least therefore we can try to minimize the amount of harm that they're causing to the public. And I also have found, as someone who's written to respect parental refusals of immunizations, that as you develop long-term relationships with these families, the number of parents who refuse all vaccines is actually quite small. Many are hesitant, they're looking to delay some vaccines, they're looking to change the schedule. The more we sort of incorporate these kids and families into our practice and show respect for them, the more they come around to, in a sense, accepting some of the vaccines some of the time. I also always tell all of these families one thing, which is I keep a list of all my vaccine-refusing parents, because in the case of an emergency, I have no qualms about sending this data in to vaccinate these kids, so in case of an epidemic. And yet, because of the fact that I get this text from the state of Illinois yesterday, the one child I know who hasn't had a measles vaccine, who's 3 years old, I sent a text to the mom yesterday and told her that she should really think about getting gamma globulin or an MMR vaccine today. Whether that's happening, I don't know. I'm here in Seattle.
John? I think Delantos was next.
So let me make three distinctions in this case. One is legal versus ethical. Legally, a physician can dismiss people from their practice. Ethically, I think it's a little more problematic. The ethical, I think, if you actually look at how this works in the real world, this is an issue of private practice pediatricians versus pediatricians working in safety net hospitals. So people in private practice feel like they have the right to control who's in their practice. People in safety net hospitals don't. If you talk to the pediatricians in private practice, many of whom say, I can't take care of families like this, I morally object, or have a conscientious objection, or use the AMA language, we have an intractable disagreement which prevents me from continuing to be this family's doctor. You say, what's going to happen? They say, well, they'll go to the public health clinic, or they'll go to the university or something. They'll get their immunizations or not, but it's not my problem. And so the third is sort of professional codes versus kind of the service orientation of medicine. So I think all the arguments that we should do what's in the best interests of children are sort of service orientation. Professional codes, though, are about doctors' rights and doctors' freedoms, and they all specify that doctors have the right to decide which patients to treat or not to treat based on even more dastardly considerations than this one, like whether they can pay.
Go ahead, Norm.
A couple things. First, as Lainey says, the vast majority of these parents are not likely to refuse all immunizations. And, you know, I assume Doug wants us to consider this as a last resort and everything else has been tried. But we should just make the point that everything else should include bargaining and negotiating with parents. You know, will you at least get the hepatitis vaccine and the H flu vaccine? That is the ones that are really important. The actual, or whichever ones you think are the most important, we could argue with. Well, hepatitis is the most common cause of death of unimmunized children, not in childhood, but later in life. So if you want to talk about lives saved, hepatitis would be the most. But we can decide that. We can talk about which ones. But my point is, most pediatricians are successful in bargaining with these parents to at least get some of these, or in different doses, if not all. Second, the actual empiric risks to the child of being unimmunized are quite low. That is, a resident and I worked on a paper on this. The order of magnitude of the risk of death or serious disability from being totally unimmunized in America in this day and age, the order of magnitude is in the 1 to 20,000 to 1 in 50,000 range. So this is like,
that you're talking about in America. I just
That's
want to
right.
emphasize,
Yeah, no,
right,
absolutely.
because there are 500,000 deaths from rotavirus and another 500,000 deaths from measles in Africa. But when you're living in a community in which most people are vaccinated, I just think that's an important detail.
no, but
So they're all free riders.
That's right. But the fact is that to go to war over a parent for doing something which is much less risk than riding a bike and playing hockey and lots of other things, it seems to me is excessive. Third, in the other situations, the other cases that we've talked about so far, we talked about drastic last resort things like cutting off the testicles or sending a kid to foster home. But the argument for doing those last resort things was that maybe it's in the interest of the child, that maybe this is the last thing we can do that would help. Firing the kid doesn't help the kid. That may soothe the practitioner's conscience or make him or her be rid of somebody that they don't like dealing with. But how does that help a child? And as Laney said, if everybody in the community acted this way, then we have what? A family that has no access to any pediatric care? So I want to speak against firing these children. There's all sorts of other things you can do for this family that are helpful. And if you're loyal to them and respectful of them and try to negotiate, who knows, maybe you can get them to take a few shots.